a risk. Today's session is on conducting a risk assessment. This webinar supplements the toolkit to end childhood lead poisoning being developed by UNICEF, which is more prescriptive in nature. The purpose of this webinar is to provide real-life examples of risk assessment in different locations. My name is Bret Ericson, and I am a consultant with UNICEF. The webinar will last 1 hour and will be comprised of 3 presentations, each 10 to 20 minutes in length. We will hold a brief Q&A at the end of the session. Please feel free to leave questions in the chat or raise your hand during the Q&A. So as I said, this is the 3rd webinar in the series. Recordings of the first 2 webinars on understanding sources of lead exposure and on carrying out a blood lead level survey are available on our website. This webinar series will continue throughout the year, as part of which we will address a range of topics related to lead exposure. Our 3 speakers today are Zeineldin Elmikaty. He is a 5th-year Egyptian medical student. Larah Ortega-Ibañez. She is the country director in the Philippines for the NGO Pure Earth. And Dr. Casey Bartrem. She is the executive director and senior environmental scientist at TerraGraphics International Foundation, or TIFO for short. So without further ado, I will introduce Zeineldin. He is, as I said, a youth ambassador for UNICEF. He is a 5th-year medical student from Alexandria, Egypt, and currently completing clinical rotations in the toxicology department at the Alexandria University Hospitals, where he frequently deals with lead poisoning. So without further ado, Zane, if you'd like to share your screen.
Thank you so much, Bret, for the introduction. I'm going to share my screen right now. Okay, great. Hello, everyone. Good morning, good afternoon, wherever you are. My name is Zeineldin Elmikaty, like Bret introduced, and I'm a 22-year-old medical student from Alexandria, Egypt. I'm also a public health advocate with the International Federation for Medical Students Associations, and I'm here as a youth ambassador for the UNICEF. So I'm currently completing clinical rotations in the toxicology department, just like Bret mentioned, in the Alexandria University Hospitals, where we do in fact see a lot of lead poisoning cases. So during one of my clinical rotations, I saw something that completely changed my perspective. A little boy, about 7 years old, was brought in by his mother. He was so weak, he could barely sit up, and his eyes had this dull, lifeless look. He was in so much pain, his stomach hurt, and he was just exhausted. And there were clear signs that his brain wasn't working the way it should be. This was one of the worst cases I've seen. In cases like this, where a child presents with unexplained neurological symptoms, severe abdominal pain, and signs of developmental issues, lead poisoning is one of the conditions we consider, especially in Egypt since it's common. When his blood lead levels came back, they were very dangerously high. After talking with the family, we were able to identify the source of lead exposure for the child. We learned that his family lived in one of the underserved areas outside Alexandria, where our university hospital often receives patients. Their home was near a small, unregulated workshop where old car batteries were being dismantled. Every day, his family was exposed to lead-contaminated dust and soil without even realizing it. And I just remember I just stood there watching the doctors try to do their best to manage his symptoms, but I couldn't stop but think about how preventable this was. And the hardest part was knowing this wasn't some rare occurrence. It's devastating to think that something so invisible, so silent, can harm so many children, stealing their health and their futures. Moments like these have made me realize how urgent it is to act, not just in the hospital, but also beyond it, and to address the root of this child health crisis. To get more in depth about the situation in Egypt, the statistics are very high. According to the Toxic Truth report, about 25 million children have blood lead levels that are above the threshold identified by the WHO as a cause for concern. The root causes are multifaceted and deeply embedded in our society, and they include children working in pottery production or battery workshops. Industrial areas like the garbage city in Menchet Nasser of Cairo has been identified as one of the worst areas affected in Egypt. And also children exposed to high traffic roads like in Greater Cairo and major urban cities. And although leaded gasoline has been phased out, the lead residue from decades of use remains in the soil and road dust, and vehicles moving along these roads stir up this lead-contaminated dust, which children can inhale or accidentally ingest while playing or during daily activities. And while efforts exist, they remain fragmented. I've observed knowledge sharing practices in my hospital, but these are just not enough. Egypt suffers from a critical lack of data to guide evidence-based approaches, and also the lack of a structured monitoring program for blood lead levels. This gap not only hinders progress, but also limits our capacity to target interventions effectively. As a representative of the International Federation for Medical Students Associations, which is abbreviated by the IFMSA, which is a federation that unites over 1.5 million medical students worldwide, with 133 national member organizations in more than 120 countries. I've engaged in public health advocacy at the local and international level over the past few years. My work with the IFMSA has motivated me to pursue a career in public health, specifically in advocacy and policy work, and I also plan to pursue a master's in public health to deepen my understanding of public health systems and strategies. My ultimate goal is to work with NGOs and other organizations to really advocate for vulnerable populations and also implement community-driven solutions and address pressing global health challenges, just like childhood lead poisoning. This is why the IFMSA urges all stakeholders, from policymakers to practitioners, to recognize the invaluable role of youth in combating lead exposure, because together we can prioritize evidence-based approaches by investing in data collection and research. We can also strengthen global, regional, national, and local policies to eliminate sources of lead contamination, and also empower youth organizations to lead grassroots initiatives, bridging the gap between communities and global action. And lastly, to increase the capacity of healthcare professionals to address childhood lead poisoning. Thank you so much for giving me this opportunity to share my perspective and represent the IFMSA in this vital discussion. And I think it is high time that we work collectively toward a lead-free future for every child. Thank you again. And back to you, Bret.
Zane, thank you so much. That was great. Really interesting to hear that perspective. I appreciate it. Thank you. Our next presenter is Larah Ortega-Ibañez. She is the country director in the Philippines for Pure Earth. Larah is a graduate of the public administration from the University of the Philippines and has been professionally engaged in development for the last 17 years. She rendered various roles in the country's media-based nonprofit ABS-CBN Foundation and the Department of Environment and Natural Resources, DENR, before serving as the country director of Pure Earth in the Philippines. She currently manages program and portfolio implementation to help stop toxic exposures, protect human health, and restore environments. Recently, she's been working with the national and local governments and concerned sectors to pilot and institutionalize lead poisoning prevention efforts in the country. Welcome, Larah.
Thank you, Bret. And I'm honored to be here, and great work, Zane. Thank you for sharing that with us. So tonight, or your morning, I'm going to share about the lead exposure risk assessment approaches and key considerations from the Pure Earth Philippines experience. First, let me talk about the Pure Earth way of doing things. And that is, one, we collaborate with government, industry, academia, and CSOs, basically the stakeholders, to identify and implement solutions backed by sound data that are cost-effective, which means applicable in the context in which we work, sustainable, hopefully, and also impactful in that it will render measurable results. And then we prioritize with limited resources and limited time available. We fix our eyes on our goal for doing these things, and that is to stop toxic exposures, to protect health, to restore environments in low and middle income countries like the Philippines. So on key approaches in the Philippines. Well, once upon a time, we had a global inventory project, which is now known as Toxic Sites Identification Program. And on the screen, you can see the report that was done by my colleagues in 2012, basically doing a roundup of 120 assessed sites in the country. And you can see the map there, and it generated workable data for the government to look into possible contaminated sites in the country across regions from all different types of industries, and how these are distributed by region and even the type of industries, and many other data presentations to be used for decision making. As Zane mentioned earlier, it is important that we act based on evidence. And so this led to the Toxic Sites Identification Program of Pure Earth, and Philippines participated in that. And so in the Toxic Sites Identification Program database, you'll see there the Philippines and the sites that we have assessed here. Basically, to give you an idea of what's inside the database, is that you'll see there the information about the site industry, the key pollutant, the blacksmith index, when was the initial site screening completed, what is the status, whether it's still a legacy site or an active site, and the investigator involved in that particular assessment. And the assessment is basically a quick process of looking into the pollution source, the pathway, and most importantly, the population or the people at risk. And also in the country, I think we are the only ones who did first targeted site assessment, which is the typical TSIP approach, which means we do it from, we look for point sources, so it's fixed and not mobile, with concentrations that can cause adverse human health impacts, and with clear migration route and exposure pathway to humans. And initial site assessment is going to be done when it's identified as a risk of high risk. Then we do a detailed site assessment, particularly if we do have funds for intervention. So this is a particular site which is in San Simon, Pampanga, and we were able to do a community exposure mitigation work in that particular area. I'll discuss more of that later. So this is the whole process of a targeted site assessment leading to a community exposure mitigation, which is actually should be the end goal of every source exposure assessment. Like, we don't just want to know the levels of contamination, but we must decide how to address that contamination. So you start with researching the site history and the nature of contamination. And then this determines the sampling dose to determine the extent of the contamination. And then to do the risk assessment model using the actual data that you have gathered from on-site, so that it will inform the response actions that should be prioritized in that particular area. So a lot of things can come out of an initial site assessment. It can delineate the zones of contamination. It can help us prioritize the response, and then clean up residential properties if possible. So in that particular example, we did the mapping here. And then we ended up identifying, say, this is the facility. Here there is a community, and you can see it's all red in that part where the households are. And so we worked with the local government, the industry, and the regional government to be able to do community exposure mitigation. And that involved laying geotextile over the lead contaminated land, and then on top of it, covering it with clean soil that's free of lead. So 2 feet, but in this particular area, I think we had more because it is a low-lying area and it's usually flooded. And then there was this sort of like a small warehouse in the compound where the industry is just dumping all their materials. And so it was asked of them by our Department of Environment and Natural Resources to take care of that and remove that so that it's not putting to risk the health of the ones living around the area. For the homes, these are actually the homes of the workers in the lead smelting facility. And so it's a conflict decision. We cannot really rebuild homes because it will incentivize them, staying in that particular area. But still, we have the moral obligation to help them be free from from exposure. And so we help them clean up their homes and give them advice on what they can do to mitigate their exposures. On the other hand, when we do things like this, we have to involve the community, and that means involving the barangay health workers, raising awareness on lead, what is lead, where it comes from, how does it get into your body, and what are the impacts, and how can you protect yourself from exposure. And then we did also health education and blood level screening for the workers, the children, and the mothers in that area. The other approach that we piloted in the Philippines on TSIP is the investigative site assessment, which means it's more extensive and random sampling approach to evaluate heavy metals concentrations across the city, whether we know there is a point source or we don't know there is a point source, in an effort to understand the geographic distribution of selected heavy metals in superficial soil samples, so that we can help the city set up their baseline levels and at the same time potentially identify hotspots if there are in the city. So we did this for Iloilo and Tagbilaran. So we can consider this one as a more proactive, preventive approach for areas where there is not much pronounced contamination yet, and yet the government would want to take a preventive approach into things. So far, based on what we have done in the past, our data on lead exposure sources show that we do have lead releasing industries in the country. We have lead handling establishments, which was inventoried by the government back in 2017. Lead contaminated sites in our database at that time, around 50 with lead as the main pollutant, with an average reading of close to 57,000 parts per million. The challenge here is that recently we don't have recent assessments on our end and even on the side of the government, and that continues to be a challenge, I would say, in countries like ours as to sustainability or being a regular part of programs being conducted on the environment end. So using our TSIP data, we can make a stronger case for lead, and all the other recent publications, the Toxic Truth Report, the Lancet, and presenting all these negative health impacts of lead poisoning on children, especially, and also to adults. And this number of 800 million children being poisoned by lead worldwide, 90% of which are in low and middle income countries, is really compelling for us to really do something about this. So when we talk about lead, we're not talking just about the environment. It actually impacts our health. For children, lost IQ points; for adults, risk to cardiovascular diseases. And economically, it also is costing all of us really huge amounts of money, because when it's not addressed, then it turns out to be an environmental cost, a health cost, and all other lost potential can be accounted there. Now, in the country, in the Philippines, we do have policies and standards in place. Just a quick slide to show that when it comes to the environment, water, air, and soil, we do have the standards. I would like to just point on soil that we just follow the standards set by the EPA, because we don't have our national standard, and we don't have specifically a contaminated lands law. And then on consumer products, food, drinking water, cosmetics, and all others, we do have standards there, especially imposed by the Chemical Control Order for lead and lead compounds. So there are also previous studies on consumer products, moving now from the environment to consumer products, that there is lead contamination in a number of items available to the public or being sold in the markets. And this is the reason behind our rapid market screening. This is done by Pure Earth in 25 countries. Again, Pure Earth Philippines is part of that, and we obtained samples from our markets, Luzon, Visayas, Mindanao, to test for lead levels. And then the home-based assessments. This is a follow-through of our blood lead level screening in the Philippines, where we went to some of the homes of those with blood lead levels and tested items in their homes to check for lead contamination in those particular items. So for both the rapid marketplace screening and the home-based assessments, I have shown in the slide that we do have protocols for such. And I just circled here the X-ray fluorescence, XRF. The Pure Earthers love the XRF, which is the tool that we use, the equipment that we use to test as many samples as we can on the field and get results right away. It is very helpful in that it can give you data right away and also direct your further confirmatory testing via the laboratory. So recent data on lead exposure sources when it comes to consumer products. I just highlighted 3: metal cookware, ceramic foodware, and household paints. You can see that's consistently showing up, whether it's in the global RMS, in our local RMS, and even in the home-based assessments that we were able to do in Metro Manila. So again, when we do source assessment, even on consumer products, or when we do blood lead level screenings, the end point, the end goal will always be to address the sources. And this is an ideal process being done in the US, where upon learning that the child has elevated blood lead level, and an inspector goes to the home to investigate, do the home-based assessment, identify the sources, and the government support continues until that particular source is addressed. And we hope that happens in the Philippines as well. All right, the second half of my presentation will be on the key considerations. One, to be able to do environmental source, lead source, exposure source assessment, it's important to have a protocol, viable how to do things. It's a scoping process, one that can be done easily. So our protocol can tell you what to do before, during, and after the assessment. It's important to have a portable equipment, again, to inform you easily of the data points. And then from there, you can collect which ones you will send to a laboratory for confirmatory testing. So it saves you also on cost. Template forms that are easily available and can be filled up by the investigators. I'd like to highlight also that the process should be applicable to train technical and non-technical local personnel, because it's important to involve local people in these types of assessments, and applicable and adaptable to local context. Second would be, before I move there, I just want to say that if you go to the link I put in the slide, we have new protocols available at Pure Earth, the metal cookware leaching test, and the protocol for testing metal cookware for lead and other toxic metals. Second key consideration, partners, because we can't stand alone. So from the government to the academe to the industry, in the professional societies, the CSOs, the local champions who are very, very important in getting this work done in the community members, they all must be informed and must be involved in the decision-making, in the planning, even in the implementation of the work on exposure source assessments. Third would be preparation, which is, I'd like to highlight the appropriate messaging we use. In terms of dealing with government, we have to be clear about the message that we're here to help them in these areas of work. And then for the industry concerned, we're here to help and not halt your operations. Basically finding in your process the hotspots for contamination and finding out alternatives for those. And then the community, to assure them that there will be feedback of results, that there will be intervention, if possible, to clear the expectations. And I think it's important to let them know that the motivation behind this is not just to study them or come up with data for government to use or other stakeholders to use, but to really care for them and their well-being. Third will be intervention, where everyone can contribute. So the key thing in exposure assessments, it should lead really to mitigation or remediation to stop the contamination at source. And if possible, there should be pre and post blood level screening to show the effectiveness of the intervention. Government plays a key part in terms of sustaining the efforts by institutionalizing the interventions in terms of like the policy, in terms of programming with funding. This is very important because nonprofits like ours can exist in a certain area and intervene for a certain period of time with their limited resources. And the hope will always be that after capacitating and doing a pilot, for instance, in that particular area, then it gets continued through government support. Industry to commit to process improvement. For instance, for consumer products, can we have lead-free alternatives to these products? For the academe and the professionals to take part in the capacity building in training, healthcare workers, for instance, or environmental health workers, and for the community to raise awareness and advocates and link them to services or offices in the government where they can ask for help. The other key considerations would be, I think it's important to pilot or pilot something or show a proof of concept. When you recommend something and it's proven already, you've done it already, then it gives it a stronger possibility of being adopted. And then to take into consideration the possibility of proactive or preventive approach to such things, because sometimes we just wait for the worst to happen before we act. And by that time, it's sometimes impossible to have the resources and the technologies to address something. So proactive, preventive approach is still advantageous. And then people of skill, I think that's a given, but also of principle, because for these types of work, it is very important that the people we engage are the people who will carry it through from beginning to end. So thank you for listening to my presentation. I just want to encourage everyone to drive action on all fronts, whether it's about looking into poisoning sources, looking at the pathways, or even intervening at the very community, the populations at risk, because the children deserve lead-free futures. That's all. Thank you very much.
Thank you, Larah. Thank you very much. I'm a big fan of Larah's work, so that was fantastic to see. Thank you very much. Our next presenter is Dr. Casey Bartrem. Casey is the Executive Director and Senior Environmental Scientist at TerraGraphics International Foundation, TIFO for short. TIFO is a non-governmental organization. It's an NGO that provides assistance to communities to address environmental pollution impacting human health. It was founded in 2017. Dr. Bartrem has led environmental health projects in Uzbekistan, Kyrgyzstan, Bangladesh, Nigeria, and the U.S. in close collaboration with local stakeholders, government representatives, humanitarian organizations such as Doctors Without Borders, MSF, and other NGOs. From 2010 to 2022, Dr. Bartrem co-led the Zamfara lead poisoning response, working with Nigerian authorities, local stakeholders, multilateral organizations, humanitarian groups, and NGOs to address the worst outbreak of lead. So yeah, I'm very happy to have Casey present. And I should also say that Casey is presenting on very short notice. So yeah, thank you. We had some folks drop out for personal reasons unavoidably. So I just want to say thank you, Casey, for presenting, and it's really a pleasure to have you here. So thank you very much.
Thanks, Bret. Thanks for that introduction. And I'm really honored to follow two wonderful presentations. those are tough acts to follow, so I'm going to do my best. I'm filling in today for Simba Tarima, who's unable to join for personal reasons. Simba is a close friend, in addition to being a longtime colleague. We both worked very closely together in northern Nigeria, so I'm honored to give this presentation on his behalf. As Bret said, I'm with an organization called TIFO, and we've worked in Zamfara and Niger states in northern Nigeria for 12 years, alongside local and state governments, traditional leadership, Doctors Without Borders, multilateral organizations, local NGOs, the list goes on. I'm going to use the word we a lot in this presentation. And when I say we, I do not mean TIFO. I mean all of those partners together. This is really a locally led project, and I have the honor of presenting it to you all today. Zamfara is widely recognized as the most severe outbreak of lead poisoning in modern history. Rarely do we see in the environmental health community chemical exposures that result in morbidity and mortality. But in Zamfara, lead exposures resulted in the deaths of more than 400 children. And so in that respect, this example I'm going to go through is not representative of what most individuals who are taking on environmental health projects, lead projects, it's not representative of what you would be seeing in those situations. But the approach that we used to identify sources of exposure and address those exposures can absolutely be adapted and applied at sites around the world. So despite the severity of the situation, which was truly devastating, the basic principles of risk assessment, going from exposure to the human, to the source, to the human receptor, are really the same. So we'll start with how the outbreak was discovered and which steps were taken to address the issue. Zamfara State is located in northwestern Nigeria. And in March of 2010, to make a long story short, rural health workers observed strange symptoms in children that they could not explain. The children did not respond to medical treatment for diseases typically found in the area. MSF was notified, Doctors Without Borders. I'll use the acronym MSF throughout the presentation. They eventually sent blood samples to Europe for heavy metal testing, and they came back exceptionally high in lead, so high that actually the lab told them that they'd done it wrong and there was cross-contamination, which ended up not being true. The lead levels were higher than anyone had seen before. At this point, local officials and Doctors Without Borders reached out for support from other organizations, including the U.S. Centers for Disease Control, World Health Organization, and TIFO. The impacted communities were in two local government areas known as Anka and Bukuyum. These are exceptionally remote areas in Zamfara State. Little to no infrastructure, no electricity, roads that are impassable during the rainy season. And I'm laying that out so that you understand this is a very low resource setting that everyone was working in. We went into this investigation knowing that blood lead levels were quite high, but what we eventually discovered was that they were literally off the charts. Average blood lead levels, were above 170 micrograms per deciliter. When you compare that to the WHO threshold of 5 micrograms per deciliter, you can understand why we say they're off the charts. This is higher than the picture, the diagram on the screen that's widely used to describe the health effects of lead exposure, and is why there are so many children who were severely sick and dying. I'll go into the details of the environmental investigation in just a moment, but what we learned was that in about a 6-month period, 400 children had died from acute lead encephalopathy, a mortality rate over 25% in most villages. More than 18,000 people were impacted. And we initially worked in 2 villages, and that's really what I'm going to focus on, was that initial risk assessment that we used. But we later learned of more villages. We ended up working in 10 villages across 2 states throughout the entire period of this project. If we move now to assessing exposure and risk, the severity of the outbreak and the suspicions of the local leadership helped us really guide this project. We had heard and knew that there was a lot of artisanal or small-scale gold mining going on in this area, and the leaders suspected that that was related to the children being sick. We also knew that blood lead levels were alarmingly high. And so we know as environmental scientists that the most common route of exposure to lead, which we'd identified from those blood lead samples, the most common route of exposure for young children is ingestion. It's not dermal exposure, certainly. It's rarely inhalation. We know at mining sites around the world, soil and dust exposures tend to be the major contributors to children's exposure. So we really started our investigation there. Every step of this process was done in close collaboration with local actors, as I mentioned earlier. And I also mentioned that this was a really low resource setting. So we had to adapt our methods to work within the local context. So what I'm about to show you is going to look very simple And that's because it was supposed to be. It needed to be something that could be replicated and used again and again and again without a lot of technology and access to resources. With the permission of the village heads and each individual household, we entered homes as multidisciplinary teams to conduct assessments. And we started by interviewing parents, mostly mothers, about their children's health, asking about mining. You can see some of the images of the homes in this slide. These are open-aired, mud-walled homes. We drew maps of these homes using handheld XRFs, which is a field portable device that's been mentioned already. This is used to test for heavy metal in soils. We tested different areas of the homes for lead, and I'm going to show you what that looks like on a piece of paper from one of the homes. So this is a map of a home. The exterior is the wall that surrounds the home. Most of it is open air, but there's small rooms for storage and for sleeping. In red, we've indicated the soil lead concentrations determined by XRF. You'll notice that the concentrations are highly variable. So if I highlight one here, we have a concentration of 221 parts per million in comparison to the current US EPA screening level, which was just lowered from 400 to 200 parts per million. About 10 meters away from that last concentration, we have a level of 54,000 parts per million. And if we continue to look, this room has two concentrations. One is 193 and one is over 1,300. And we see that all over the compound, there are routinely levels over 10,000 parts per million, but also that it's very heterogeneous. It really depended on where people were processing or storing ore, and those were the places that had been contaminated. So we had to thoroughly test the entire home to determine where the contamination was located. We found overall in the first village we worked in Argama, that more than 70% of homes had a maximum soil lead level over 5,000 milligrams per kilogram. And again, we were routinely finding levels over 10,000, 20,000, 30,000 parts per million. Before I go any farther, I want to very quickly explain how this severe contamination came to be. I can go into why it happened at the specific time it did during Q&A if that's of interest, because there were several events that transpired to result in this happening in early 2010. But right now, I just want to go through the mining process, which is displayed on this slide. The ores are sourced from mines around the region and previously were brought into villages to be processed. That's a really critical part of this story, that the processing of these ores was being done inside residential areas. The rocks were broken into small sizes by hand, usually like gravel size or almost like a bean size piece of rock. And those were put into modified flour mills and ground into a very fine dust, very fine powder. Then that powder went through a series of washing and drying stages, all of this again happening in residential areas. This resulted in massive quantities of ore dust being distributed throughout the villages. Unfortunately, the gold ore in this particular part of the world contains a lot of lead, up to 10% lead, or 100,000 milligrams per kilogram. So this was deposited in residential areas where children were eating and sleeping and playing, as you saw on that map previously. This is a very simple and very critical piece of the story I want to make sure we take forward, and that is that kids eat dirt. And I don't just mean Nigerian kids. I mean all kids. Everyone on this webinar when they were a child ate a significant amount of soil. In fact, there's whole areas of science dedicated to estimating how much soil we eat as children every day. And anyone who's spent any time with a 2-year-old child knows that if you were to hand them an object, whether it was a pen or a cell phone or a toy, the first thing that that 1 or 2-year-old child would do would be to put that object in their mouth, and that they put their hands in their mouth multiple times per day. So many times per day, they end up ingesting a significant amount of soil and dust that's on their hands and on those objects. This is something that's a very normal behavior. It's how kids learn about their environment. But it also means that if they are exposed to soil and dust that has lead in it, they end up ingesting a significant amount of that contaminant. Young children mouth their hands and objects so many times per day, they ingest anywhere from 80 to 300 milligrams of soil just by mouthing alone. And that's what the kids in these photos across the top of the slide are doing. They're exploring their environment and unintentionally consuming soil and dust. We know that soil contamination was a direct ingestion risk, and in Zamfara, it resulted in really high blood lead levels. And I'll come to a conceptual site model in a moment that will show you that. But what we also learned was that there were dietary exposures going on because of the way that foods are prepared and served on the ground in these communities. So we ended up testing grain samples and did a food intake survey to assess dietary exposures to lead as well, and found that it contributed between 8 and 34% of the total blood lead of the total blood lead levels. So using information from soil sampling, water sampling, which I didn't show you, but we did test, and food sampling, we were able to estimate the relative contribution of lead from all of these different sources. We found that at least 65% of children's blood lead levels were likely due to incidental ingestion of soil and dust, and that could be up to 85% depending on the community and the situation and the age of the child. We found water contamination to be very minimal, probably amounting to at most 10% in some homes of children's blood lead levels, but most of the water sources were completely fine. And then, of course, we identified that foods contaminated with soil dust during preparation in the homes, when that soil and dust that was already contaminated found its way into foods being prepared, that accounted between 11 and up to 34% of blood lead levels. So at this point, we're really clear on what's going on and that we need to find an intervention to take all of these arrows that lead to this child and break them. We knew that local leadership had already banned residential ore processing. They'd ordered it moved to camps outside the villages, but the contamination, of course, remained within these communities. And so the single best intervention when it comes to contamination is to remove the source of exposure. That's what we always have to be working towards. And that was the intervention that we went to. So in order to remove that contamination, environmental remediation was needed. I won't spend too much time on this today since we're really focusing on risk assessment, but wanted to quickly show you how the assessment informed an intervention, because we're always thinking about that intervention piece throughout this process. Doctors Without Borders was ready to treat severely poisoned children, but the medical treatment, the chelation treatment, is predicated upon exposures being stopped. And so these children had to live in clean environments before they could receive medical care. So what we did was work very closely with our partners at local and state governments, as well as traditional leadership, and we jointly developed an emergency remediation project. This was with technical support from TIFO and other partners. And the remediation involved the removal of contaminated soils from homes and public areas in the villages. This was done using locally available agricultural tools, and the contamination was removed and landfilled. And we had to remove only 1 to 2 centimeters of soil in most cases. This remediation, to take a long story and make it short, resulted in dramatic reductions in soil lead levels, about 89% on average, and a dramatic reduction in blood lead levels, going from a geometric mean of 185 micrograms per deciliter to under 20 micrograms per deciliter in just 2 years. And this is independent of medical treatment. So it would be very easy for me to end the story here, but with just a few more minutes, I want to make sure to touch on the fact that these projects take a long time. The sustainability piece is undeniably the most difficult piece of this. And so really quickly, I want to speak about the need for expanding these assessments to continue to look for additional sources of exposure to determine if your intervention is working and how you can improve that intervention. We periodically reviewed blood lead data in the communities we had worked in, which MSF was collecting as a part of their routine treatment programs. And we watched for blood lead levels that were not responding to treatment, or that perhaps even were going up instead of down. And we knew that those were homes we had to spend some time working in. So we went to those homes and assessed for recontamination or other sources of exposure. And we also worked with communities to determine if the ban on mining in residential areas was working. And of course, we worked with the government to assess any additional needs that they had. In the interest of time, I'm only going to show soil results. I'm not going to show results of other pieces of the assessment that we did. The This graph is showing you pre and post soil remediation lead levels by village, each village represented in a different color. So you can see when we go from pre-remediation average soil concentrations across an entire village to post-remediation that the levels decreased significantly. But now what you're seeing is at different time points after remediation that soil lead levels in some villages started going up. The checkered hashed bars that are not solid fill are from homes that were not randomly selected. So this is homes we went to because we knew that blood lead levels were high. So that's not representative of the entire community. The solid bars are representative of the entire community. So you can see in Doretta as an example in 2010, this green solid bar is showing you average lead levels shortly after remediation. And we can see that it's gone up since immediately following that remediation. And we see that in other communities as well over time. We found the reason that this was happening was because working materials, such as the sluice board that these children are standing on in a home, these working materials were being brought back into homes to be stored for safekeeping at the end of every day. So this was introducing contamination back into the homes. We also found that some ore processing was happening in close proximity to the village and not at the designated mining camps that had been set up by the local leadership. And so what we did is work with the local government to develop what's called an institutional controls program. That's a US term, but basically that means that a program had to be developed that was locally developed and implemented to control these para-occupational or take-home exposures. And so in Nigeria, this looked like health promotion, occupational health and safety training. There was some biomonitoring that was still going on as part of the treatment program with MSF. There were culturally and economically appropriate tools that were developed to ensure that we could prevent this cross-contamination from occurring. Village councils were set up. And ultimately, a program was set up where homeowners could self-report if they thought that their home may be recontaminated, and supported with supplies to do self-remediation of their home to remove that contamination. And what that resulted in is that same graph. If you zoom out a little bit more, we can see that lead levels are starting to go down during the self-remediation program once that's been implemented. And so that's really the whole goal of the program, is to keep those lead levels below the action criteria, which at the time was 400 milligrams per kilogram. Of course, EPA has recently just lowered that to 200. All right, so in conclusion, I just wanted to talk about three big takeaways to take with you. The first one for this project for us was engaging local leaders at multiple levels from day zero. You'll learn more about the sources of exposure and understand the problem better, develop a stronger intervention, and local leaders will really be more integrated and bought into the project if they're involved in the beginning and not if you just hand them the results once you're done with the assessment. You want to make sure to focus on major sources of exposure and then immediately start addressing those. Then you can also start investigating secondary sources of exposure, but you don't have to know everything about all the sources of exposure at once before you start an intervention. You can tackle known issues while screening for additional sources and start bringing those blood lead levels down as soon as you can. The third one is that risk assessment is detective work. It's fun in that regard. But you have to remember that it's just one step in the process, and the goal is always about developing that effective intervention. So keeping that long-term goal of intervention in mind throughout the process is critically important. And I think the other presenters have really highlighted that need to always be moving, not just for a study, but towards that intervention piece. So with that, I'm going to thank everyone and hand it back over to Bret.
Thank you, Casey. Sorry for the delay there. Yeah, that was excellent. Obviously, it's a really moving example. It can be hard to listen to at times. Just so folks are aware, some of the levels we saw there, 50,000 parts per million in a home. That's 5% lead inside of homes where kids are living. So that's poison. That the ground they're playing on is poison. So just really impressive work, Casey. Thank you for presenting on it. All right, so what I'd like to do now, also, oh no, I like the point about how it's an investigation and it can be fun. I echo that. Having done a lot of this work myself, it's exciting to go out there and identify what the source of exposure is. So what I'd like to do now is open it up to questions. So if I could ask, oh, Larah's got her camera on. Zane, if you'd like to put your camera on either way. We have a few questions in the chat that we should probably get into, and then we could open it up for live questions. So Larah, the first question is for you. Also, thank you, Larah, for answering some of the questions offline. Could you share insights regarding institutionalization or mainstreaming of these processes and learnings into government and industry's regular programs? And Casey, if you'd like to weigh in on that as well, but Larah, welcome.
Yeah, okay. So this is important for us because I think Pure Earth Philippines really works towards that, even up to now, institutionalization of our efforts. So for the TSIP effort, the government was informed of this and given access to the database at the time to help them in their prioritization. I'd be honest that it's not as ideal as we would like it to be. That's why we recently, we shifted to not just environment, but also environmental health, looking into blood lead levels, because in countries, for low and middle income countries, I think environmental problems don't get really prioritized. But if you connect it with health, it's something that needs attention, whether we like it or not. And so it's important to have that link. And then for the investigative type of TSIP, we develop guidance documents for the local government units to use in their land use planning and in their standards in terms of for the future locators into those areas. And then for the other, like say the RMS and the HBA, it's part of our institutionalization efforts right now. I'm happy to report that it's now part at least of a government document, a National Environmental Health Action Plan, where for the first time after so many years of working on lead in the Philippines, we have at least 10 action points relevant to lead in the National Environmental Health Action Plan. And that's where we are at the moment, following up into turning those plans into action. Aside from that, if I may just add, Bret, it's part of Pure Earth's approach that whenever we are in a particular location, we do capacity building. So we train their people to do what we do. And I think that's part of mainstreaming the processes and learnings that we have. Yeah.
Thank you, Larah. And Casey, I don't know if you'd like to come in or if we should move to the next question.
I think Laura gave a fantastic answer to that question. I don't know that I could build on it too much.
The next question I think is for you, Casey. So, and it's really the last two here in the Q&A. So it says, may I ask Casey how the burden of blood lead levels was determined, food versus dust and so forth? Did you use isotopes? And if you look at the last question there too, which source has more lead contamination and comparative measure proportions available?
Yeah, these are great questions. Thank you so much for sharing those. Isotopic analysis is a really exciting new area in lead risk assessment. It is also not necessarily easy to do. You need to have really specialized laboratories and able to pull that off. It's quite expensive to do. So fantastic area of research, but we didn't have those kinds of resources to be able to implement that. We used modeling in order to determine which sources were contributing most to blood lead levels. And that's something that's actually fairly straightforward to do because we know so much about lead exposure and biokinetics in the body. And so what we did was we looked at the concentration of lead in soil and in water and in some of the grain samples that we found. And we were able to estimate based on those concentrations, how much they were contributing to the blood lead levels. And we were able to do that with age-specific estimates. There's two models that are of use, the Integrated Exposure and Uptake Biokinetic Model, IEUBK, and the All Ages Lead Model. Both were developed by EPA. They're fantastic tools. Anyone can download them and use them. They're free to use, and they're exceptionally powerful. They are developed for US scenarios, but they can still be really useful. And we certainly relied on them in terms of looking at relative contributions to different blood lead levels in Nigeria. In some ways, we couldn't use them any more than that because they're not intended for blood lead levels that were as high as we were seeing in Nigeria, but I would encourage folks to use those. If you can measure the environment and then use that data to see how much those environmental concentrations contribute to blood lead levels, you actually don't even need blood lead level testing in order to be able to determine what the relative risk is of those different exposure sources.
That's great, Casey. That's thank you very much. Do we have a list of lead sources responsible for health hazards? Casey, Larah, do you want to take that on, or is that? I'll let Larah go since we just heard from Casey. That's okay. Larah, do you want to?
Yeah, okay. A list of lead sources. Well, I just say that when it comes to the environment, it will be primarily the areas where we found lead smelting and used lead acid battery recycling industries, whether it's formal or informal. And then on the consumer product end of things, as I mentioned earlier, for us, it's a new thing to find cookware. Even locally manufactured cookware contaminated with lead, and then ceramic foodware, paint, even if, for instance, in the Philippines, we do have a ban on lead in paint already, or standards is set in place. We still have findings of lead in paint, contaminated paint, also the toys and other articles concerning children. Yeah.
Casey, do you want to come in?
I would just say that, you know, again, there's always the temptation to try and understand every source before you develop an intervention plan. And I can understand that as scientists. We all want to have as much information as possible to act on good information. Laura covered all the or at least the majority of the sources. You have industrial sources like recycling, mining, e-waste recycling, all of these other industries. And then you have the consumer product sources, which can contribute significantly to blood lead levels as well. If you know that there's an existing source of exposure and you've identified that, you can act on that source of exposure while you continue to investigate other sources. And I think that that's an important thing to take forward.
That's great. And I just wanted to point out, so we have the existing tool for this, tool 3 is considerations for risk assessment in a resource-constrained environment. It addresses some of these concerns, and so I've linked to it in the response to one of the questions above, so thank you. We have a question here on, so it looks like they've found some elevated blood leads, or elevated lead in breast milk in India. And the question is, it seems I've lost it, so I apologize. Oh, the question is how to make this project at the local level more effective. And then I think after this, we'll just take 2 more questions. So Casey, I'll let you lead this, and then Larah, I'll let you come in if that's okay.
Well, the first thing to do is figure out how that lead is getting into someone's body, right? So you need to do an assessment to determine where those women are being exposed, because that's then not only exposing the children via breast milk, but presumably there's also fetal exposures going on, which are exceptionally dangerous and probably going to be really impacting the child's blood lead level before they're even born. And so the source assessment is the initial part. How are women being exposed? And there's different tools, as Bret mentioned, in that toolkit of how you can assess potential sources of exposure. I don't know, Laura, if you want to add anything there.
Yeah, maybe I'd add from an institutionalization point of view again, in that when we advocate for blood lead level screening to be institutionalized as part of regular surveys of the government, we advocate not just for children, but also for women of reproductive age, so we can catch that. And also to take it further, although this is on the health end, we are actually advocating that these testing will be covered by our universal health care. You know, if it's available at your primary health care units down at the localities, if it's available in the state hospitals, that it makes it easier to detect exposures. As we usually say, early detection results to early intervention. Yeah.
So I think that's just about all the time we have. We have some great questions in the chat. One here about root causes that I wish we had time to get to. We also have just several comments saying thank you for your presentations. So yeah, I'd like to thank our panelists, Zane, Larah, and Casey. I really enjoyed that. That was excellent. I learned a lot, so really appreciate it. And I hope everyone will join us for our next webinar, which will be on February 24th. And that's about developing country strategies on lead exposure. So perhaps there we'll get into this sort of this root cause discussion. So thank you again to all of our panelists, and have a great day or evening, as the case may be. Thank you again. Bye-bye.
Thanks, everyone.
Thank you.
Thank you, everyone. Goodbye.